My name is Nicolas Van Mieghem. I'm an interventional cardiologist of the Thoraxcenter, Erasmus University Medical Center. I'm here at the ESC meeting in Munich. We are already at the fourth day, four days of late-breaking trials. And today I will give a wrap-up of potential highlights from my perspective. First of all, let's start on Saturday, where there were a couple of interesting trials. The first one was the FUTURE trial, which was a trial produced by French investigators. 1,700 patients enrolled, where the revascularization strategy was based on FFR. Patients were randomized to FFR-guided treatment versus angio-guided treatment. After randomization, patients could be treated either medically, CABG, or PCI. Turned out that an FFR-based strategy was not effective in improving outcomes. As a matter of fact, the trial was stopped after inclusion of 980 patients because there was an increase in mortality in the FFR-guided arm. The trial raised a lot of discussion among the panel, and also Professor Serois himself mentioned that probably this trial added much more confusion to the space. There are some open questions there. For instance, what kind of treatment were the patients getting? Was there a treatment effect? So we will learn probably more in the weeks and months ahead. A second very interesting trial presented on Saturday was the culprit shock, the one-year outcome of the culprit shock. The 30-day results were presented last year, and it was very interesting to learn there that in patients with cardiogenic shock and STEMI, complete revascularization was not better than a culprit-only revascularization. As a matter of fact, culprit-only revascularization was better, and that extended out to 1 year. So there is no catch-up in the patients who could benefit from complete revascularization during the index procedure. What we did see was that after 30 days there was somewhat of an increase in revascularization. There was a 30% increase in revascularization in the culprit-only arm compared to, I think, 5% in the complete revascularized arm. And there were also more hospitalizations for heart failure in the patients in the culprit-only arm, 5% versus 1% in the complete revascularized arm. But still, at the end of the day, this study seems to give us enough data to support a culprit-only strategy in patients with cardiogenic shock. The second day of late-breaker trials, I would like to highlight, first of all, there were the aspirin trials in primary prevention. You had the ASCENT and the ARRIVE. One trial in diabetics, the other trial in patients with an intermediate risk of coronary artery disease. Turned out that in primary prevention, aspirin does not have a decisive role. So aspirin comes with more bleeding, may reduce some major adverse events, but at the expense of bleeding, so the net effect is zero. So I think we have now sufficient data not to provide aspirin in primary prevention. Another trial that was highly anticipated on Sunday was the ART trial. That was a trial comparing BEMA, so the use of two memory arteries in CABG versus the use of one memory artery and then saphenous vein grafting in the remainder. This trial, out to 10 years of follow-up, became a negative study, and that was not anticipated. Surgeons have been proclaiming for years that the effects of the use of a bilateral memory artery use would only appear during long-term follow-up. Well, that does not seem to be the case. There was a lot of discussion around that trial. Also, Professor Taggart, who was presenting the trial, complained a little bit of the expertise of the participating surgeons. Not all surgeons were as expert users of the bilateral memory approach. But that said, I think we are talking about a randomized trial, and I think the bar of CABG did not change in terms when you look at it from a PCI perspective. I think surgeons are doing a good job whether they use one or two memories, but just the use of two memories is not better than only one. On Monday, we had a couple of blockbuster trials. The first one was the MITRA-FR trial, which was the first randomized study in patients with functional MR and heart failure, randomizing them to MitraClip or control, or to a control arm. The trial was a complete negative study, so there was no effect of the use of the MitraClip. although we have to take into account that in the control arm, patients at 1 year were also doing better. So their symptoms improved. So basically what we do not know from the presentation is whether the medication use changed in the control arm. So this raises questions to whether these patients were optimally treated at baseline, so before they entered the study. That said, it was a blow for the MitraClip space, and it only adds more importance to the COAP trial that will be presented at this year's TCT meeting later in September. Following the MITRA-FR, that was the Global Leaders trial, which is a trial, a revascularization study evaluating new anti-platelet therapy, so ticagrelor, prolonged use of ticagrelor in monotherapy up to 2 years, both in stable patients and in patients with ACS. Also there, surprising findings. At 1 year, there seemed to be a difference in favor of the patients who were treated in the prolonged single ticagrelor arm, but at 2 years, and that was the primary endpoint, there was no difference in outcome between the standard treatment of DAPT for 1 year and then continued single antiplatelet therapy versus prolonged ticagrelor treatment. This was somewhat of a deception, that study, but the facts are what they are, and I think that with Global Leaders we will not change our guidelines. On the other hand, I think in patients where you face issues during their DAPT treatment, it is safe to stop one of the two, or the aspirin therapy, so to drop the aspirin therapy and continue with ticagrelor in monotherapy. The last trial on Monday that was of interest from my perspective was the EORP VHD Il registry, which is the follow-up of the Euro Heart survey. It evaluated 7,000 patients treated with valvular heart disease in 2017. 80% of those patients appear to be treated according to the guidelines, so that is an important message and definitely an improvement as compared to the Euro Heart survey more than a decade ago. Also, 40% of the patients with valvular disease had aortic stenosis, so aortic stenosis remains the dominant valvular disorder that requires treatment. And finally, TAVI was already used in 40% of the patients undergoing treatment for aortic stenosis. The last day of the late breakers is Tuesday, and today we already had the VERDICT trial presented. The VERDICT trial was a randomized study evaluating very early PCI in patients presenting with a non-STEMI. Patients were randomized to a very early strategy or a more delayed strategy out to 12 hours after the procedure. At 1 year, there was no difference in the composite endpoint between a very early or a more planned coronary angiogram. In subgroup analyses, patients at a higher risk with a gray score above 140 seem to do better with a very early strategy. I don't think that the VERDICT trial adds any new to our common sense and our current practice, although we have to be aware that patients at a very high risk presenting with a non-STEMI may do better with a very early or a speedy coronary angiogram. So one more interesting trial to be presented later today is the LRT registry, evaluating TAVI in patients at low operative risk. Unfortunately, my plane will leave at 2 p.m., so I'll miss the results. I will catch the results though on the internet. Thank you for your attention and hope to see you again later. Bye-bye.